our series. I'm Saumya Mayappan. I'm manager of the Learning Health System here at Women's, and very excited to have you all in kind of our, I wouldn't say our season finale, but we'll take a little bit of a break over the holidays before we come back in January. And as you can see on the screen, as always, we record these sessions. So previous recordings can be found on our website. I think that link is clickable. And for any questions, please feel free to reach out to me. And before we get started, as always, we do a land acknowledgement. We acknowledge that the land we work and meet on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Before I hand it over to our speakers, we're very excited to announce, and many of you may have heard of this and may have already started using this new resource. It's the Women's College Learning Health System Toolkit. It launched just under 2 months ago. It was co-authored by myself and actually one of our speakers for today, Dr. Celia Laur. And of course, it took a village. We had a working group that really helped guide and we were able to consult with on how to create this resource designed for staff and clinicians to be active members of our learning health system. I think you are also going to be hearing a little bit more about the toolkit later on in the talk. And as you'll see in the chat, we've provided the link so you can, in your free time, go ahead and visit the toolkit, take a look around. It's designed to show you the components of a learning health system, whether it's generating data from practice. Maybe you have that data and you're trying to figure out what to do with it, how to analyze, interpret. Now that you have that knowledge, how are you bringing it back into practice? So it walks you through, there's a bit of a how-to guide, yes/no questions to figure out which section is most applicable to you. And we also have lots of examples. So this is now live on the public website, on the intranet as well. And as you'll see, a bit of a disclaimer here, we are currently thinking about how can we make this more relevant to hospital patients, experience advisors, and people with lived experience. So regardless, we welcome everyone to review the toolkit and bring forward any ideas that you may have. Okay, so I see a lot more folks joining, which is always great to see. I'm going to now introduce our speakers who are talking about connecting implementation science and learning health systems, examples from the Office of Spread and Scale. And we're actually very, very excited about this talk because we always welcome internal speakers as much as possible. It's always great to spotlight internal initiatives. And the Office of Spread and Scale in particular is very integral to a learning health system. And you're going to find out more about why in the talk. So we have two speakers today. Dr. Celia Laur is an implementation scientist, health services researcher, and a leader regarding how to sustain, spread, and scale effective healthcare innovations. As a scientist in the Office of Spread and Scale here at Women's, in the Institute for Health System Innovations and Virtual Care, as well as being an assistant professor at the U of T, she works in partnership with clinicians, individuals with lived and living experience, and health system leaders to amplify and sustain successful models of care. Celia's work focuses on using a breadth of methodological skills to achieve equitable and sustainable change, supporting effective programs to have widespread lasting impact. Joining, and sorry, there's a bit of a typo here. This should say Dr. Zeenat Ladak. I'm so sorry about that. Dr. Ladak is an equity-oriented implementation scientist with an interest in the integration of health and social care and maternal care. She earned her PhD at the University of Toronto, I believe very recently. Congratulations on that, in the Department of Applied Psychology and Human Development, and is now a postdoctoral fellow with the the Office of Spread and Scale here at Women's, and as well as at U of T. So without further ado, I'm going to stop sharing my screen and hand it over to Doctors Laur and Ladak.
Great, thank you for that introduction. We've been introduced, so I'm just going to start with our own land acknowledgement because we are based in different locations. So for myself, I am based. Um, Sorry, one second. Um, yeah, so I am situated on the Haldeman Tract, which was land that was promised to the Haudenosaunee of the Six Nations of the Grand River and are within the territory of the neutral Anishinaabe and Haudenosaunee's people. And the image that I present here is a place that I go walking by all the time. It's just down the street from my house, and there was a big push a little while ago that they wanted to actually propose this land for reconciliation and dedicate the purpose to that land. And unfortunately, there was a big push for it, and then I didn't really hear much about it, and now it's becoming a development. So this is the constant reminder of how that it's not just that initial push, but all of the effort that is needed to be able to make some of these changes in lots of different ways. And now I'll pass to Zeenat.
So hello everyone. So I live and work on the traditional lands promised to the Huron-Wendat, the Mississaugas of the Credit First Nations, the Anishinaabe, and the Haudenosaunee peoples. And the picture on the right here is from near my home at Richmond Green Park, where there's a children's garden, and in that children's garden, the city's planted prairie sage. And so prairie sage is often used within ceremonies in Indigenous culture, but also positive for the environment as it acts as a pollinator for the ecosystem. I'll pass it back to you, Celia.
Yeah, so for today, Zeenat and I are each going to do a little bit of a less formal introduction to ourselves, and then we're going to talk about the Office of Spread and Scale, the way that it came about, and a little bit of background on kind of who's involved, what do we really focus on. And then to get into more of the content, we really wanted to understand a bit more about what do we actually mean by learning health systems, and hope to present some of those concepts in a way that helps you see how that connects with the wider learning health system approach and that ongoing focus on continuous learning. And then we're going to go through an example from right here at Women's that's very fresh in my mind, as well as a national example to be able to show more about how we think about learning health systems, not just locally or in one clinic, but that wider real system level. And then we'll hopefully have some time for questions. So I came to implementation science kind of with a recognition that education wasn't going to be enough. There were so many other factors that were there, but there wasn't a lot of training when I started in this field. So I am a self-taught implementation scientist and still learning very much about how all of this works, and really got interested in not just how do we implement something, but how do we make it stick? What's the science? What can we learn from all of these other generalizable examples so that we don't keep reinventing the wheel and we keep adding and or increasing our understanding of how do we actually support that sustainability? And when something is working really well, we want more people to be able to benefit. So that led to my interest in Spread and Scale and the Office of Spread and Scale, and really wanting to be able to bridge that gap between research and science, learning from what's really going on. What are some of the questions that we need to answer on the research side so that we can then support more of those changes to happen in the real world? So that's kind of how I position myself and how I really think about the work that we do.
Okay. And so I am an aspiring implementation scientist. I would say that I've learned almost everything that I know related to implementation science from the Office of Spread and Scale and stayed on with them as a postdoctoral fellow because of the uniqueness of the office and what they do and how they do things. And I'm particularly interested in the role of equity and the role of equity from designing interventions through to implementation, sustainability, spread, and scale, and very curious about how we can use implementation science to equitably meet patients' needs within health and social care. Back to you.
So, our aim for today is to really demonstrate how implementation science, sustainability, spread and scale all really come together into that learning health system focus. That emphasis on continuous learning, continuous improvement, and really about sustaining these changes, having that wider impact. So, that's what we're hoping to be able to showcase to you today of how we're thinking about all of this coming together. And we bring all of this together at the Office of Spread and Scale, where our aim is to really turn that research that we know about what's working or not in the healthcare system and apply that to make those changes, to apply those benefits, and really using what we know from the science of implementation to support the practice change, and recognizing that some of the science gets very academic and that's not always the most useful. So how can we make sure that we're answering the questions that really need to be answered to be able to support these bigger changes? And we know there is still a lot to learn about how do we this is spread and scale from a scientific perspective, these programs so that they can have that bigger impact, and really aiming to amplify these successful models of care and learning as much as we possibly can along the way from everyone that is doing this work. And so we started out fairly small as just an idea of this sounds like something that we should really do. And it's expanded greatly over the last couple of years. So we have several projects that are fairly local, like right here in the hospital. How do we think about the learning health systems, supporting the development of the toolkit that Salmia mentioned, as well as providing input to some teams that are really in the weeds about how do we make this work. As well, there's other projects locally, and quite a lot of our work is provincial. So, how do we think about getting more of these programs across the province, or maintaining that sustainability, really bridging the research and the practice side. We also have quite a few national projects and national networks that we're connected with, because a lot of these things happen through networks and through these more much wider scale partnerships, because none of this work can happen in silos. And one of the more international examples that we're quite excited about is that we now are the host for the Audit and Feedback Meta Lab. So this is led by Dr. Noah Ivers and really emphasizes that recognition of how do you collect the right data and provide the feedback on it that's a way to make those changes. So really aligns well with that focus on the learning health system. But it's also one of the areas within implementation science that we know a lot more about, and a lot more specific strategies about how do you actually report this information in a way that incorporates the way that people think and the way that people work. And that international network is one of the ways to be able to study that area. So for all of our work, we have big emphasis on the research side of things, but research in a way that is very practical, very driven on what is the actual benefit of this, whether it's a direct benefit working with people individually, or whether it's the benefit that's more of that underlying science so that it can have that wider impact. We also do some consulting, recognizing that research projects and other teams might just need more advice along the way. There's a really growing interest in this field, in that focus on sustainability and spread and scale. So how can we provide more of that ongoing impact in more of a consulting capacity? And with that growing interest, we also want to make sure that we build up everyone that comes with us. So have multiple ways of thinking about that capacity building focus, whether it's individual students that are joining our team on a regular basis, through to our discussion groups, which are a really exciting place at the moment. We're getting a really good interest from it. They're just a 10-minute presentation, and the entire rest of the time is just open for shared learning and discussion. So I've got the slide at the end that provides a bit more information about that. So this is our team. We are quite wide-ranging across scientists, parts people with lived experience, trainees, research coordinators, which each bring our own perspectives to this work and really integrate that multidisciplinary or interdisciplinary approach to all of the work that we do from the full spectrum, recognizing that if we're thinking about that bigger impact, a lot of the times you need to think about that right from the beginning of a project. And how do we emphasize that recognition of planning for sustainability, planning for that bigger impact all the way through. And each of us brings a different focus within the implementation methods as well as the clinical areas. at. And we work with lots of different partners. So we've been funded through multiple different organizations, both locally, national, or provincially, and nationally, and are able to um, work and learn together with all of these different organizations that provide support in different ways, and recognizing that they might there's some disparate needs, but the same goal that really comes through on making that bigger impact, and how do we go about doing that. So lots of really strong connections that we hope to be able to continue to leverage over time and build and strengthen a lot of these relationships. So now I'm going to pass over to Zeenat to get into a little bit more about what do we actually mean when I say implementation science, and a little bit more of that background.
Thanks, Celia. So I think it starts with the fact that it can take so long to go from research to practice. On average, it takes 17 years to do this, and many reasons why. There's many barriers in place structurally, for example, limited resources, resistance to change, and much more. So change is hard, so it takes this amount of time. But implementation science can help, and it can help bridge that research to practice gap. Next slide. So often what happens is a miracle occurs, right? Things happen, you go from A to B, we don't know why. And implementation science can help with figuring out that miracle, because oftentimes, if we go through our animations here, we never hear about the miracle again when it happens. And then all of a sudden, 17 years later, it takes place and people start using it. So implementation science can really help us understand the why, the how, and the when of when things take place so that we can do things better in the future. Next slide. So, a few more reasons why implementation science is important. We know that research evidence is often not being applied within practice and policy. Care isn't always delivered in a way that's evidence-based, and effective pilot interventions are not typically continued, so they're not typically sustained or scaled. And so there's this no-do gap, and we want to systematically close this gap between what we know and what we do by identifying and addressing the barriers that slow or halt uptake of proven health interventions and evidence-based practices. And implementation science can help us close this gap. So I've been saying implementation science, there's also implementation practice, and there is a difference between the two. Implementation science is the study. So, the study of the methods and the strategies that facilitate the uptake of these practices and research into regular use by practitioners and policymakers. Whereas implementation practice is the use of strategies or interventions to support individuals, organizations, and systems to use this evidence to change practice. And a little bit more about how we can think about implementation science. This was published by Curran and colleagues in 2020, and I find it very helpful. And we tend to show this quite a bit so that it's easier for people to understand what we mean by implementation science and how to relate things to it. So we call the thing being the intervention, the practice, the program, the innovation, whatever you're working towards or working on. That's the thing. And effectiveness research looks at whether that thing works or not. Implementation research looks at how best to help people do that thing. Implementation strategies and this are the stuff that we do to try and help people do the thing. And then you have these main implementation outcomes, which are how much or how well they do that thing. So it kind of helps you understand a little bit more about implementation science and the different facets around it. So a big part of implementation science is understanding the barriers and facilitators to change, because if we can understand the barriers and facilitators, then we might know how to work around them, how to change them, when best to implement the facilitators and when not to. And so to help us in doing this, there are theories, models, and frameworks. If we go to the next slide. So theories, models, and frameworks are helpful for us to learn and apply what others have done before. And they're really useful guides. We really do rely on them at the Office of Spread and Scale and throughout different implementation science projects that we do. And theories, models, and frameworks are complex. We can't go over them all today, but we have a couple examples to help you understand what we mean by these theories, models, and frameworks and why they might be useful. So, for example, there are determinant frameworks, which I would say are quite commonly used within implementation science projects. Determinant frameworks specifically help you in identifying barriers and facilitators to the innovation that you are implementing, sustaining, or scaling. Um, these frameworks help with structure to identify barriers and facilitators versus just, guessing what they might be. Really helps you understand the context with your innovation, and helps to name what's going on and learn from others' work who've had the same barriers. So, other projects that have used the same frameworks, for example. And this framework here is an example of a determinant framework, the theoretical domains framework, very widely used. And these are just a couple list of examples of barriers and facilitators that could be involved within your innovations. So, for example, the skills of an individual who might be delivering the innovation, the social influences around why a behavior might be taken up within that innovation. So just a couple examples here. And there's lots more frameworks that you can use as well for barriers and facilitators. Next slide. Another example here is a model. So the first one was a framework. This one is a model, specifically a process model. So process models help you figure out what steps to follow, what to do next. Often they show, a linear or circular path. It's not always true, or you don't always have to go in that path. It's often an iterative process. You're kind of going back and forth, or you kind of see what works for you. But it's helpful. It provides a sequence of actions that you could take. This here is an example of the knowledge to action framework. Very useful, starts with knowledge inquiry, goes down to identifying a problem, later on assessing barriers and facilitators. So good opportunity to kind of combine theories, models, and frameworks, perhaps use a framework, determinant framework to assess your barriers and facilitators as part of this model. It goes on to evaluating outcomes, sustaining knowledge use, and then it kind of circles back to the beginning. So again, knowing that you don't have to use every part of the process and you don't have to go in a linear fashion, but these models are super helpful in knowing what to do within your work. So why are these theories, models, and frameworks important? They're a good place to start from, again, so that you're not guessing what to do. It gives you a bit of structure, provides foundation to build the design of a new program or service, helps you plan next steps, provides structure, and it helps to connect your results with others, because if your project uses one framework and someone else's uses the same framework, there's a lot of shared learning that can go into how you use the frameworks and the learnings that you've gathered from applying those frameworks. And I'll pass it back to Celia now.
Thanks. Yeah, it's a great introduction to a couple of the things that we're thinking about all the time in terms of how do we use that science? What are we continually building on? But we all know that unfortunately, a lot of the times when something is new and it's great, it's a pilot. And even if it's working or it's not, that doesn't necessarily mean that it's going to be able to keep going. And we need to keep going, and we need to be able to continue that when something is having that benefit that is really meeting that need, how do we sustain it? But when we ask that question about how do we sustain it, what are we actually asking? Are you talking about sustaining the actual program itself? You're sustaining the policy, the practice, the program. That's the what in terms of what you're actually sustaining. Or are you sustaining how that's actually happened? Is it the education that's being delivered, the different processes that are within that program? So are you those strategies for actually getting something to be used? Or is it really just about those outcomes? However that gets to it, you want to make sure that those benefits that you have for that patient, for that provider, are really continuing. And so being clear about what you're actually trying to sustain is really important, because you may, and it builds on what we really connect with, is the need for adaptations when we're talking about sustainability. And this is where I really start to see that connection with the learning health system. So do you need to actually adapt the program itself? Is it continuing to meet those outcomes that you want? Is the population of the hospital changing, or the population of your clinic? And you need to be able to adapt what is actually being delivered. You might also need to think about how it's being delivered. Is it the frequency that that a program is occurring, or frequency of visits or education? Does that need to change to be able to keep it going? Is it something that's more realistic, or maybe because it's working very well, there might be some things that you might be able to decrease, which is always nice to know that you don't need to put quite as much to be able to keep it going if you've got a strong enough foundation. But always making sure that you want those outcomes, but sometimes it's reflecting on if you're measuring those, are they the outcomes that you really want? Are they the outcomes you need? Do they match with what the program is? And those might need to change as well. So it's that ongoing focus on knowing what's going on. How do you make those changes? How do you improve and learn from the data that you're actually collecting so that you can continue to have those ongoing benefits? And sustainability is messy, as all of these things are, because the context changes, the capacity for individuals changes. So that might influence how this is being delivered. So thinking about what adaptations are needed if your staffing level changes, for example. You don't want this to be able to just go away because one person is gone. So how do you build in more of that infrastructure so that these adaptations can be made and continuing to have those benefits that you want? But sustainability is dynamic. There are tools that can help think through. We know a lot more about what are the real factors that you need to be planning for as early as possible to incorporate it, but then recognizing that this is an ongoing process. Just because you've planned for sustainability doesn't mean that doesn't need to change over time as your population or the people that you're seeing really changes, or other contextual factors that can change. Unfortunately, we also know that a lot of the times this was a new program that had lots of incentive, there was lots of excitement around it. And then the next new program comes around. There's lots of excitement around that one. And it means that original program that there's a high potential for a voltage drop afterwards. So, how do we acknowledge that that might happen? How do we prevent that decrease from going? And how do we build in more of that infrastructure to be able to say that this is something that's just part of regular practice, and ideally decrease the amount of that voltage drop? And again, bringing this back to the learning health system where we're embedding the technology that's needed. Is it built into the EMR so that that question will be asked? What are the checkpoints to be able to see if people are actually asking that? Is it still having this impact? And using that data that you're getting to be able to say, is this program still helping the patients it's supposed to? And if it's not, how do we bring that back up so we don't have as much of the drop in voltage? In many cases, it's also about trying to keep it a little bit more simple. So it doesn't always work this way, but I come across a lot of projects, especially research projects, that have so many different components to them. And it might have this amazing impact, but it will never be used anywhere else, or a very unlikely. I don't want to be too pessimistic, but when there's so many components, how is another place able to be able to take that on? So understanding which are the key pieces of a program that really help the most. What would you want to stay if funding changed, if the program changed? What would you want to keep that was able to have that biggest impact? And knowing and collecting some of that information is really important. And again, going back to what needs to be adapted in order for this to continue, and that is an ongoing conversation aligned with the learning health system approach. We'll also say that there is a question within sustainability that I do not think gets asked often enough, especially in the research side, when you have people that are very dedicated to an idea. But the question is whether something should actually be sustained. Right. And if we've got the data that doesn't really align, there's always different pieces in that decision, but it can't just be because one person thinks that it's doing well. You need that data to be able to back you up, and recognizing that sometimes that the answer is no. And that needs to happen to be able to allow for the next thing that can actually meet those benefits that you're looking for to be able to continue. So continually asking, is this something that should actually be sustained? Should it continue to adapt enough that it keeps having that benefit? Or in some cases, does it actually just need to be phased out or stop because it's not doing what it's supposed to be doing? Right. Um, and the other piece that comes up all the time within sustainability and that adaptation focus is that mix of fidelity and adaptations. So we if we know that a program has been tested in a way, these very strict conditions, we know that it had that benefit, there's the idea that you want to stick to those strict conditions. And we do, because we want to be able to mimic that. But we also know that every place is different, every setting is different, the people that are being seen are different. So recognizing how you can stay true to those original purpose and get those outcomes that you're really looking for, but also adapting to the needs of the people that you're working with. And those adaptations could be a bit different. So in some cases, you might have more of like the pumpkin spice Oreos, where you are changing to be able to meet the surroundings. And maybe that's your way of really gaining a huge focus on attention, and you get people's ideas and you get the excitement because this is something new and you've made those changes. Well, it might also provide the opportunity for more of the accessibility approaches, or like the gluten-free Oreo that can now be made available because that is a need that's there. So really thinking about how much you can maintain of that initial fidelity to what you're planning to do, and how do you make sure that you're still having those beneficial outcomes with the adaptations that you're making, and that focus on ongoing learning. And so if we've got a program or an initiative, or what you're working on is having that positive impact, you've got the numbers, you can see that there's the benefits, you can hear from the patients that you're talking to. We want more people to be able to benefit from that and to be able to learn from that success. And that's where we really bring in that spread and scale focus. So it might seem a little bit pedantic when I say the differences between spread and scale, because you hear these used interchangeably all the time. But when you're actually thinking about planning for spread and scale, I think it's helpful to think through some of these differences, because the questions that you're asking and the processes that you're taking can be quite different, whether you're thinking about spread versus scale. So if you've got a program that's working in one clinic here at Women's and you want to be able to get it used in another clinic at Women's, that's more of that spread. You're going from one site to the next, or from one hospital to the next. And you want to understand what the context is of that new setting. How do you make that work? Who are the champions? What are the details that be able to get you into place in there? And if you can make it work in one other place or anything, that is a huge win and takes a lot of work. But at the same time, you might also be thinking about how would you get this across all hospitals or across the province? And that would be where you're talking about more of the scale. And what's the infrastructure that's needed to be able to make that program scale? Those are different questions than what does it take to get into one place. So that's where I see more of that distinction. And both of these can be happening. And in many, many cases, they're both happening at the same time. But if you're planning for one site versus you're planning across a province, the approaches that you're taking and the strategies that you're using can be quite different, for having that wider impact. And unfortunately, we know that in many cases, that spreading and scaling in both can be more spontaneous or more opportunistic. Somebody's ready, they've got the interest, which is great, and you want to be able to build on that. But that can also mean that it is much of a less equitable approach, because if you're only going to those that are ready to take this on, it may mean that for example, the higher resourced settings might be more able to benefit from some of these more rapid opportunities, which may leave other programs behind. So those that are ready keep getting more and more, and they benefit from there, leaving the rest behind. So really comes down to thinking about your plans for spread and scale, recognizing more deliberate efforts. It might take a lot more effort to be able to get it used in certain places than others, but recognizing if you want more of that equitable approach, that's going to be needed. For example, you see it fairly often that an urban program suddenly wants to be used in a rural area. So you don't want to lose that opportunity, but also what are the adaptations that need to happen there to be able to make that work? Or maybe it's a different approach to be able to get at those same benefits. So these are all of the questions that we need to think about to make sure that we are taking more of that equitable approach to spreading and scaling. So it isn't always the same people that are benefiting. And all of these pieces come together in a learning health system, as I keep mentioning. So this slide is from the toolkit, where we're thinking about how we learn from the experience or the practice of the hospital. We're converting that into the data, and then using that into the knowledge and converting that back into the practice sides of things. So that ongoing focus, we want the sustainability of the impact. We want that ongoing learning so we can continue to have these adaptations. Right. So now I'm going to get into a bit more specifics of how this can actually come together. So I've got an example from right here at Women's. I am only been working on this as part of this team for the last couple months, but we're really trying to develop a long-term evaluation plan. So this is for the Postpartum Matters program, and we're trying to take a learning health systems approach to the development of this plan. So, for those of you that aren't familiar, Postpartum Matters has been running for a long time at Women's. It was originally called Mother Matters, and as part of this a new opportunity, it was now funded to run a few different groups. So it's an 8-week online support group for women and gender diverse individuals that have a baby that's under the age of 1 year. And so they individuals meet the eligibility criteria and are then put into a program. And so there is content that's created that's been shared with the individuals, and then there's also ongoing discussion boards and connections with the therapists. So it's all online. People can come from anywhere across the province, and for those 8 weeks, there's a new topic each week. And the program currently has funding to develop specific streams for Black parents and young parents, and then everyone could have the option to be in an all are welcome group. So there's a pilot evaluation that's looking at the details, there's the new pieces, so all of that is ongoing. But where I come in is that we want to be able to use this opportunity to develop more of the structure for how can we make sure that we've got it as easy as possible to have this ongoing evaluation. So really developing that governance plan. And to be able to do that, we need to have the data that's being collected on a regular basis. And some of that is clinical data. So developing it so that the Edinburgh postnatal depression score is used at multiple points throughout. So before somebody starts the program, and again later to be able to see if it's having that impact that we're hoping for. And also an anonymous evaluation survey, just to be able to get feedback from the participants. From the discussion boards, we're looking at the platform usage data. So this is around the number of people that are engaging with the material, which topic from which week seemed to have the most engagement. There was some where there's early engagement at the beginning, but a couple of topics where it was really quick for people to respond. So that topic hit really well. Or it took a really long time, so they were less engaged in some of those. You can think about how those might change the way that you want to be able to adapt your materials. Also documenting recruitment plans. So this is working with strategic communications and knowing what are some of the strategies that have already been used, what have been tried but didn't work, so that when you think about this a year later or 2 years later, you have this documented saying, this is the reason we didn't go down this route for recruitment, or this one was really good, we should try that again. And what I'm trying to do is to figure out all of these pieces so that we can have that plan for what would actually be feasible after this main part of the project is done. What could be done on every 6 months, for example? How would we have that structure to be able to say these are the things that are working well? What could we use to improve, and having that data-driven approach to understanding what's going on. And where the implementation piece comes in is that we're using an evaluation framework. So this one's called RE-AIM. If you're familiar with any implementation or evaluation framework, this one is fairly common. So we really put the emphasis on the sustainability side of things. So we just want to know for reach, the number of patients that are being served, and ideally their demographics, and how can we collect that in a way that is easy to do on an ongoing basis. Effectiveness, that EPDS score, and the patient feedback. So what do we know about what that changes over time? The recruitment strategies for adoption, and how does this align with the priorities of the hospital at the moment? As that changes, is this still a good fit? Are we still meeting the same population or the needs of the hospital? And from the implementation side, we're in the process of developing the goals for how many groups would be feasible to be able to run, how many groups of the Black parents group would be feasible to run in a year, how much engagement are we hoping for across these discussion boards, those kinds of questions. So it gives us a benchmark to be able to say, yes, we're on track, we're meeting what we should be doing. And really bringing all of that together into that maintenance focus. So this is just an example of the platform. This is fake data, but how often did people interact with the platform? What topics were most of interest? So it kind of fell off, and then there was great interest in like week 3, kind of came down a bit, and then really sustained interest for a while. So mapping this back to which weeks were these, to be able to know where you might want to improve some of the material, if people are really low engagement on certain content, that you can assess going forward of what you might want to be looking at for the program. So this is very much a work in progress. Is still learning all of the details, connecting with Epic, seeing how we can build this in a way that is actually feasible. And what we're also seeing is that we're kind of in the in-between stages at the moment. So it's not at a state that would be ready for um, just regular practice. And a couple of the things that we've needed to do seem a little bit more on the research side, but we need the data to be able to know how we can build this in, or the time that it takes to be able to build this out a bit further so that it can be more sustainable. And that kind of in-between space is where I feel like we're at the moment for the work that I'm doing. And really recognizing that this is quite different than just the initial pilot. How is that material being received? This is the plan for how we can look at this as a more ongoing example. So for my last example, before I wrap up, this one is quite a different approach, different focus, and really on that provincial and national emphasis for what we're thinking about. So this is a project that is CIHR funded as part of the THINK grants, which are the Transforming Health Through Integrated Care. And the aim is to focus on scaling and using a learning health system approach. So for in Canada, and especially in Ontario, there is a global shortage of rheumatologists. And that is occurring at the same time as there is increasing patient volume, treatment complexity, and more need for this service. And what's been found in terms of the evidence is that having that team-based model where it has an interdisciplinary team, so other social worker, or not social workers, occupational therapists and physiotherapists that are working alongside a rheumatologist as part of the team really has high potential for improving patient care, outcomes, equity, population health management. So for this work, we're really looking at what are the research activities that we can be doing to understand this process and really drive it forward, while also the communication pieces, because research, just having papers is never, ever going to be enough for this work. So how do we get this messaging? Who are we talking to? What are our partners? And how do we really drive this, this forward in terms of that planning for the scale of this model of care? And as I said, this work can never happen alone. So working very, very closely with the Ontario Rheumatology Association, with other rheumatologists, with other healthcare professionals, with trainees, all to bring this together as part of our team, so that there can be more of a coordinated effort to drive this forward, looking at it from multiple different perspectives. And the way that we've been following is our kind of roadmap to spread and scale. Uh, so started with understanding one case. We went really, really deep into this one example, looking at the actual model of care, the interviews with healthcare professionals, patients, observations of what was going on, and brought that out into we're calling an implementation logic model. So we're understanding what were those pieces that really went into it. What were the barriers and facilitators to that care? What are the strategies that were needed to make that happen? We also needed the evidence, and I'll come back to those strategy piece because that's been a key component all the way through. So we also needed to collect the evidence on what was actually working, so the effectiveness. So the patient experience, the health outcomes, the cost, the well-being, the health equity focus, and also developing some long-term cost effectiveness studies. So I'm not as much involved in these pieces, but the knowing how this would be funded, what is needed, are a big piece within this overall plan. We also needed to understand if the rheumatologists were actually ready for this or what they thought. So there was an environmental scan that identified who the actual rheumatologists were in Ontario, where were they based, and having that more geographic distribution, as well as asking questions around, would this be something that they were interested in? Would there be any, what would it take to be able to have somebody bring on somebody, like have a rheumatologist bring on somebody else to their team? What would be their concerns? How would they go about that? And then also did interviews with rheumatologists about that do not work as this model of care, but what are their concerns? What would they need, so that we can make sure that that's built in to all of these plans. And upcoming is bringing all of this together and getting feedback from key informants at different managerial and policy levels to bring that forward. And recognizing all of the budget and the population impacts, and then how do we connect all of these different pieces into those spread and scale plans? So developing policy briefs, a more detailed policy report, an implementation plan of how would we actually get these into place. And we're also developing a toolkit that would support teams to actually implement it. A toolkit on its own is never going to be enough, but combined with these other elements, the right people at the table are all aiming to build that forward. And where the learning health system piece, it's coming in the way that we're planning it, but the focus on the future is that there's also going to be an evaluation plan. So knowing which metrics we actually need, how would we keep that going so that that data could be collected and can be continuously built into making sure that these teams are still having those benefits that they are intended to do. And so that's leading to, although our focus is provincial, all of the resources and all of the materials that were created, or most of them, all have that much more national and international benefit to understand all of these different pieces that are needed. And again, bringing it back to the implementation science, it's built into each of the elements that we're thinking about. So I'm not going to go through each of these, but every study that we've run generally has a framework or a model that's there. And what's been also quite interesting, and as I mentioned at the beginning, the spread and scale sides of things hasn't really been that developed in the implementation space. There is a bunch of tools and a bunch of frameworks, but they haven't really been helping that much for this work. So they bring a lot of ideas, and you can do that, but not as much for some of the specifics. So it really highlights the need for more understanding about this process beyond just some case examples of how can we build that evidence a bit further. Right. So I think I've talked about these, but there's so many pieces, so many more research questions to ask. This could be a never-ending project, but we also know that it shouldn't be, and that research isn't enough to be able to make this happen. We're trying to be able to build this, but if we didn't have these connections, or the other team members didn't have all of these pieces, this would never get anywhere. So it's really those connections with the partners that focus on ongoing learning, and how do we build this into the system from the beginning. So this is quite a different example than the one locally, but I think it's important to think about learning health systems on a much bigger scale that are also relevant. So just going to put in another plug for the Learning Health System Toolkit, because a lot of the concepts and pieces that we've talked about here are also mentioned or linked out to within the resource or within the toolkit. And it's meant to just provide you with a place to start and directions for lots of other ways to, lots of other places to go to learn more about this. And I forgot to update my slide, but putting a push for the discussion groups. And the next one has, Zeenat can correct me on my title, but I believe there is a equity focus, because I forgot to update my slide. But if you go to the QR code, you can see our discussion group for February, and they're always open. Always, everybody is welcome to join in, whether you've got a question or not. We're lucky we've got a pretty engaged group, so somebody normally has got something to say that gets us started on those groups. And also just push on our website, which we can put in the chat as well. We have these resources that we use in our presentations. So these are more designed for introductions to implementation science for people with lived experience, but I think they can also be quite helpful for anyone that wants to take a quick look at some of the things that we think about. So I'm going to stop there.
Thanks so much, Celia and Zena. That was a great talk. I think that, and I've seen like we've hovered around 50 or so participants. So I'm always happy to see, and hopefully you're seeing new folks as well who may not be as familiar with this office and reaching out to them. And I really liked your theme of building up everyone that comes with us, because that's really the whole point is to, you want to scale and spread, but also how do you support and build that capacity? We'll go to O'Neill. We'll open up the floor for questions.
All right. Thank you, Celia and Zeenat, for a very clear and very comprehensive talk. So I have one question. You have the how, the what, the what, the thing you're trying to implement, the how, the strategy. And I'm curious, what does the literature say about how we adjust implementation strategies as we move across an adoption curve from like innovators who came up with the thing to early adopters, and then early majority and so forth. And how your implementation strategy in theory I think would have to change. I mean, would have to change as you move across an adoption curve. And just tell me what's known about that. What can you say about that process in the rare instances where things actually get past an early adopter?
Yeah, so it's still definitely an area where I think we've got a lot more to learn. I think there is examples where certain strategies seem to be a lot more. And some work there is a list of all of the, well, not all, but a huge list of implementation strategies, and they've been adapted for sustainability as well. So more of that ongoing focus. I think some of the strategies are a bit more long term, that might just need to change in terms of their frequency. So some of the like advisory groups or coalitions that kind of continue but adapt, and others that we really hope don't need to continue in terms of some of the strategies or that initial education or those focused, but then knowing you might still need education if new staff are brought on or other or there's yeah, so new staff or the boosters kind of thing, but there isn't really definitive on like as far as I know, like these strategies work better for much later in terms of that adoption curve. It's more around some of the intensity of some of those strategies that are used that I think changes over time.
And I
But
put that
interesting question that I really hope we continue because that's the space that I think is really interesting for from the research side as well that I think will be really practical.
and I've put that list of implementation strategies adapted with sustainability considerations in the chat if anyone's interested.
And that list is really, it's not meant to be fully comprehensive. It's huge, but it's really meant to show ideas of what else could you be thinking about from that implementation side. People generally focus on education, but that list really helps to showcase that there is a ton more options of what you can be thinking about for different ways to get a program implemented.
Other questions? Maybe as we wait, I have one just referring to kind of the audience who's joined today, the very, diverse group that we're always happy to have. This was one way, hopefully, that you were able to promote this office within women's. I'm just curious about other ways that you do that. And then also around capacity and managing expectations of kind of what comes to your door.
Yeah, so we really try and balance some of the internal focus and benefiting some of women's, but we have a pretty huge more provincial and national focus within a lot of our work, especially on the spread and scale side, and really connecting with those networks. And we hope to be able to enhance that while also bringing those learnings back to women. So a lot of what we've been learning kind of came together in terms of the toolkit. And what we're thinking about, and Salvia, we're working on all of this, is recognizing when somebody has some of these questions, what are those resources that we can share first to provide some direction direction. And then when it gets to the next level, reaching out to individuals that have that expertise and seeing if that's a good fit or how we can provide some of that kind of one-off input of different directions that you can provide through to where there might be more opportunities for more ongoing engagement. And that's where we really see and how our capacity is doing, because there is a lot of interest in this field at the moment, which is really great to see, but having to be able to balance that with the capacity of the team.
Yeah, for sure.
But if you've got ideas and interest, we're always happy to hear from you and see where we can direct and support.
We'll go back to O'Neill.
Yes, it's a question actually come from a conversation that David Urbach led last week on central intake platforms. And I'm just kind of curious, when you roll something out, so central intake for surgery or specialty referral is something that family docs are very keen on because it makes their life easier. But surgeons and various specialists are not particularly interested in because they're busy, they don't need a central intake platform to stay busy. And so as you roll something out, you need like I'm just curious, what is known within the frameworks on the mix of carrot and sticks? Because essentially, some of these things have network effects that if like 80% aren't, providers aren't on it, it doesn't really do that much. And so some things have to scale to make a difference, but you will have variable, there's some groups, the value of it is going to vary a lot across different groups. And just curious if you had any suggestions or thoughts on frameworks that address the differential value of certain interventions.
In terms of the frameworks, I think this gets back to that I don't think we've got enough. I think the frameworks are either quite broad and like you need a scalable unit and then it scales. And these are all the contextual factors that impact it through to super detailed every stage that you're thinking of. So I'm not sure if those are really meeting the needs. So like what we've been learning from this rheumatology project is that there's so many different pieces. It's more about bringing different tools in at different times to be able to support some of that. So I'm not sure if I've answered your question, and I'm curious to hear more about what you are thinking about all of this from your side as well.
Yeah, it's a great use case, and David, that's something we can, chat about further. But I love the fact that different people want different things out of it, and you're going to probably have a mix of carrot and sticks and defaults and whatever to get to roll anything out. But your point is well taken, Celia. It's like we haven't studied. This is actually happening all the time, and yet it's rarely studied, right?
And I'll say, I think that it's in some cases it's studied, but from a case example perspective, rather than knowing what some of those bigger pieces are. And I think finding some of the ways to study the sustainability of learning health systems and the sustainability of other pieces from more of those other more generalizable areas, or bringing the different ways together as opposed to always just doing these one-off examples. And no.
Yeah, so I think, O'Neill, I would frame David's challenge as the challenge of implementing a major policy change broadly, as opposed to the challenge of spreading or scaling something that locally worked well. So it's almost like a different question, and so needs a different way of thinking through the challenge. The other thing I would say is you're right, like the surgeons, like what's in it for them. But in general, anytime we use implementation science methods, we want to use systematic approaches to understanding our end user, their beliefs, their, constraints, and so on. And so that all still applies. It's just the answers, of course, are going to be different for the different kinds of users.
Go ahead.
I think we have one more question we'll turn to, Mira.
Just to kind of add to what Noah was just saying, one of the other things that, this is amazing and it's necessary. If we don't have implementation and assessing sustainability, we have no progress on programs. So this is important, very important. Looking at it from more of the other, like a quantitative side, especially with things like policy changes, one thing that as an epidemiologist kind of look at is interrupted time series, or looking at the impact on a specific behavior change and what that has done to the end result. So because antibiotics are a thing that I'm really interested in, is like, did it change prescribing, or did it affect the specific outcome you're interested in? Because the behavior isn't necessarily always linked to an action, because there could be other factors that have impacted the want to change. So I love this, and I'd love to see it coupled with more of like the other aspects of sustainability as well.
Mhm. Yeah, that's a great point, and I think that focus on the data that really needs to continue, and for all of our all of our work, when there is that quantitative focus, it's the process evaluations that understand, and that's generally where a lot of the implementation understanding comes in, into that deeper deeper look at what's going on from both the quantitative and the qualitative side. And we're pretty lucky at the Office of Spread and Scale, because we have the people that can do that really detailed look into the medications and the quantitative analysis, while also the qualitative researchers that provide some of that contextual pieces. So when we get the chance to be able to work together and bring all of these skills together, I think that's where we've got the biggest impact within our team, which is always nice to see. So we've got a couple of examples of projects that we get to do that on right now, which is really exciting.
Excellent. I think with that, we'll come to a close with the seminar. Just want to thank everyone for staying right at the end. Our next seminar is on January 13th, so in about a month's time, and that's when we hope to share our remaining schedule for 2026 with you. Just want to thank our speakers again. Thank you for this talk. Thank you for sharing and bringing some more awareness to this important work that you're doing inside